Well, welcome to this talk on acute kidney injury. And the first thing we want to do is think about the causes of acute kidney injury. So here we have a kidney, and there's the medullary pyramids within the kidney. A few more than I've drawn here, just a simplified diagram. So we have these medullary pyramids. And leaving this, we have the ureter. And the ureter goes down to the bladder here. And then the urethra takes the urine out of the body. So we have this pathway. Now the kidney has a very copious blood supply. So we have the aorta coming down here, taking blood into the renal artery. So the kidney's got a copious blood supply. About 22% of cardiac output is going to the kidney. Because what we're trying to do in this video is talk about acute kidney injury, formerly called acute renal failure. The term acute kidney injury is actually better because it includes people at risk of injury, people with renal failure, people with loss of function for more than 4 weeks, and also end-stage failure. So it's actually quite a clever innovation. It's inaugurated by the Kidney Disease Improving Global Outcomes Group. So it's a group of experts that have changed this. So normally what we need is an adequate blood pressure to perfuse the kidney so the kidney can generate the urine. You might remember that once the urine is generated, it goes into the calyces, down the ureter, down into the bladder, and then out of the body. Now the reason I've drawn this diagram is because we can divide the causes of acute kidney injury into pre-renal, intrinsic renal and post-renal quite nicely using this diagram. So first of all, pre-renal. Pre-renal causes are causes in the circulatory system before the blood gets to the kidney. So the causes are pre-renal. Then if there's disorders in the kidney itself, that's intrinsic renal. Intrinsic renal failure or acute kidney injury. But other times there's a problem after the urine has left with an obstruction in the ureter, the bladder or the urethra, and that's post-renal. So acute kidney injury can be caused by pre-renal causes, intrinsic causes, or post-renal causes. And the first one we want to think about is the pre-renal causes. So pre-renal causes of acute kidney injury. Acute kidney injury. And the most common is low blood volume, hypovolemia. If the blood volume drops, there's going to be insufficient perfusion of the kidney. And glomerular filtration is dependent on pressure in the renal arterial system, which feeds through into the afferent arterioles. And conditions which cause a hypoperfusion of the kidney, we could include heart failure in that. Because in heart failure, the left ventricle is unable to contract sufficiently or generate enough contractile pressure to perfuse adequately the organs of the body. So we could include heart failure. And here we can also include conditions that affect the renal artery. So renal arterial stenosis, for example, caused by thromboembolic disease. So even if the blood pressure in the aorta is high enough, if there's problems in the renal artery, the kidney won't be adequately perfused. And we could also include arterial disease there of the small vessels, although that does tend to be a longer term process. Now, what is going on here? Why is hypovolemia such an important risk factor, such an important etiology for acute kidney injury? Well, as you probably remember, we have a glomerulus here. There's the glomerulus leading on to the nephron, with the descending loop of the nephron, the ascending loop of the nephron. Going into the collecting duct. Many nephrons go into a collecting duct, and these collecting ducts go down through the medullary pyramids. Each one of these lines I'm drawing here would be one of the larger collecting ducts, and they're going to drain the urine out here in the medullary papillae into the calyces. But going into the kidney, we have afferent arteriole, or going into the glomerulus here, we have the afferent arteriole, and these are going to go round. They form the ball of capillaries called the glomerulus. Lots of capillaries in this space here. We'll just draw a couple of capillaries. So the blood is going in via the afferent arteriole, circulating around the glomerulus and leaving via the efferent arteriole. And we need an adequate pressure in here to generate the glomerular filtrate that's going to go in there. So there's hypovolemia, which is a very common cause of acute kidney injury. There's going to be lowered blood volumes. Lower blood volumes mean there's going to be reduced pressure. Reduced systemic arterial pressure is going to lead to reduced renal perfusion. Reduced renal perfusion is going to lead to reduced pressure of blood in the afferent arteriole. Less blood is going to go into the glomerulus, therefore the blood pressure in the glomerulus is going to be reduced. So the pressure, the hydrostatic pressure, causing the ultrafiltration of the glomerular filtrate is going to be reduced. And we're going to have lower amounts of glomerular filtrate. So that's one thing. But the blood supply of the kidney is complicated because the blood from this vessel here, the efferent arteriole, goes into capillaries, and these capillaries are in very close contact with these tubules. So this breaks that down into lots of capillaries which go surrounding the tubules. Only then does the blood drain into a branch of the renal vein. And within these tubules, if we look inside one of these tubules, imagine that's one of the tubules there. Then there's cells inside these tubules, these columnar cells. Actually, they're more cuboidal cells, lining the tubules. And these cells lining the renal tubules are metabolically very active cells. The kidney uses a lot of energy. So the blood leaving in the efferent arteriole is still highly oxygenated. And that blood is going to give its oxygen to the tubules to allow them to function. That's where they get their oxygen supply from. So if the renal perfusion is reduced, not only is there going to be lower levels of glomerular filtrate, there's going to be lower levels of oxygen and nutrients supplied to the renal tubules. And this is why this renal hypoperfusion can lead to this condition called acute tubular necrosis. There's acute tubular necrosis, and it's often reversible, which we'll come on to. But let's carry on thinking about the acute tubular necrosis, or the ATN. So we have these cells lining the tubules. So what I've drawn here is a blow-up section of, say, just here, this tubule here. And when the blood supply is reduced, so here will be the capillary, taking blood to this area of the tubule. Normally it's getting its oxygen from that blood there, going through it, going through this capillary. But now there's reduced amounts of blood going through here because the kidneys are hypoperfused because of the hypovolemia. So there's reduced oxygen getting to these tubular cells. But we've said that these tubular cells have a very high oxygen demand. Therefore, they do not do well without their oxygen supply. So if there's a prolonged period of hypoperfusion of the kidney, these cells will start to die. And when these cells start to die, they will slough off their basement membrane. So that's the basement membrane there. They'll slough off that basement membrane. And they'll actually slough off, and they'll start blocking off the tubule itself. So what this means is that material cannot flow through the tubule. And if material cannot flow through the tubule because of this blockage here, then the material, which is the fluid which is not reabsorbed, will not get to the collecting duct. So it won't get to the collecting duct. If it's not getting to the collecting duct, it's not going to get into the renal calyces, and we're not going to get the urine. But we've said that this acute tubular necrosis is usually reversible. So if we can detect this happening, usually because we notice the patient's urine output is dropping off, then this is reversible. Over time, these cells will actually wash through. They'll actually wash through into the collecting ducts, and they will wash through into the ureter and the bladder, and they'll come out in the flow of urine. And we can actually see them because it causes what we call casts, because they maintain the shape of the tubule as the acute tubular necrosis reverses. But of course it will only reverse if we restore the blood flow, if we restore the volume by correcting the hypovolemia. So it's very reversible. Early change is rapidly reversible in acute tubular necrosis, but only if we sort out the problem that's causing the hypovolemia. And I just want to illustrate that a bit scientifically if I can, because here we have a graph taken from data from Guyton and Hall, great physiology book. Now, what this graph is showing, what we have in red, we have the renal blood flow. And we've said the renal blood flow is dependent on systemic circulating volume and systemic blood pressure. And we see that the glomerular filtration rate is very dependent on the renal blood flow. But what we notice is that if the patient is not getting enough glomerular filtration, and the urine volumes are low because urine volumes depend on glomerular filtration. If we increase the renal blood flow just a little bit, because this line is very steep here, then we can restore a lot of glomerular filtration really quite quickly. So that shows that giving fluids and restoring circulating volume has the potential to rapidly increase, because we just move this red line a little bit that way and the blue line will follow very quickly, because there's auto-regulatory processes going on here. So that's one cause of acute kidney injury, the acute tubular necrosis, the most common cause. There are others. Another cause is crush injury, Myoglobin Emia causing Rhabdomyolysis. Now what's happening here is that if we think about the skeletal muscle cells, here we have some skeletal muscle cells in a muscle, skeletal muscle cells. Now, if there's a crush injury, I think you can see those cells will be crushed, and that will disrupt the membrane of the muscle cells, and that will mean that the myoglobin which was in the muscle cells can get out into the blood, and there's going to be a myoglobin emia. So the myoglobin emia, of course, means in the blood. In the States you don't have an A. So the myoglobin emia, the myoglobin in the blood. Now what happens here is and if we think about the glomerulus and the nephron, here we have the glomerulus, the nephron, the arteriole going in here, leaving there, the ball of capillaries. Now the myoglobin is such a size that it can just be filtered into the tubule. And there's the tubule. So the myoglobin can actually just be filtered out. So the myoglobin is filtered out, but the myoglobin is a long complex molecule, and it gets a bit sticky and it starts clogging up the inside of the nephron. So it's a fairly analogous situation really to acute tubular necrosis. Again, the nephron is clogged up. We get clogging up of the nephron. So that means that the material can't get through, just as with acute tubular necrosis. But as with acute tubular necrosis, what it also means is that the glomerular filtrate dams back up here. This is true with rhabdomyolysis. It's true with acute tubular necrosis. The glomerular, if there's a blockage here, remember this was the microscopic scale, so the blockage here means there's going to be a damming back here up into the upper parts of the nephron and into Bowman space. So that means there's going to be an increased pressure in Bowman space. It's going to become distended. And that's going to make it harder for the glomerular filtrate to form. Because a big part of the reason that the glomerular filtrate forms normally is because the hydrostatic pressure in here, in the capillaries, is higher than the hydrostatic pressure in the Bowman space. But now with this back pressure, the hydrostatic pressure is going to be higher. So that's going to be true for acute tubular necrosis and in rhabdomyolysis. And much the same can happen with hemolysis. If there's a hemolysis for any reason, hemolysis, breakup of the red cells, we can get a hemoglobin emia with free hemoglobin from red cells getting into the blood. So if the red cells are broken up for whatever reason, the red cells are broken up, the hemoglobin can get into the blood, circulate round, and also the hemoglobin will circulate round here, and it will be filtered out and also clog up the nephron. And again, it's reversible. This can work its way through, but it does take a bit of time to do so. So these are causes of acute kidney injury. For pre-renal reasons, before the blood gets to the kidney. So there's pre-renal causes of acute kidney injury. So we'll leave that there, and then in the next clip we'll do the intrinsic and the post-renal causes of acute renal failure.